All right, so this is the start of the next block of material for the test. I'm going to try to get through as much of this as I can in the hour that I have. Any questions from, I can't really answer any questions about the exam yet. I need to go through and validate it to see if there's any givebacks or anything, but how did everyone feel about it? Okay, not too bad. Okay. Difficult? Challenging? Not impossible, I hope? Okay, that's always the goal, right? Want you to use your noodle. I want you to, at least when you reason it out, you're like, oh yeah, obviously this is the right answer, right? That shows you really know your stuff, right? Good. Okay, so we were talking about depression, got through all of that. Now we're moving into bipolar disorder. Now again, what is bipolar disorder?
They keep changing.
Yeah, you have a manic phase and you have more of a depressive sort of phase, right? What kind of happens during the manic phase? Maybe you start spending money, maybe you start making bad decisions. A lot of energy, you sleep, your house has never been cleaner in your entire life.
You come up with 10 different business ideas.
Sure, come up with a bunch of different business ideas, all kinds of things associated with kind of the high energy. What are the extremes of that? What could happen in more extreme cases?
Or hurt somebody.
Yeah, they can become a danger either to themselves or others, right? And so especially if you think about someone who has maybe like not very well treated depression, they have these suicidal ideations and they go into more of a manic phase, they can sometimes act on that, right? So they can, you also see substance abuse can be a big issue with a lot of these patients, a lot of nicotine abuse, alcohol abuse, drug abuse, etc. And a lot of times it can be very difficult to manage these patients because when you're in more of a hypomanic or early kind of manic sort of phase, like, do they necessarily feel like anything is wrong with them? Oftentimes, no, they actually feel pretty good. They have all this energy. I can get all this stuff done. What do I need medications for this for? But it's those kind of inability to make good decisions and being able to manage that energy can be very difficult. That's where the medications come into play here, right? But you're going to find that compliance is very difficult with these patients overall because a lot of times they just don't think they need treatment. So again, we don't know what the full etiology is. We just know that there's probably some genetic components to it. Probably a lot of nature, maybe a little bit of nurture associated with this one. And we're going to find that there's probably some altered sort of synaptic circuitry here that's kind of gone awry a little bit. And so that's why you're going to find that a lot of the medications that we use for bipolar disorder, for the manic phases specifically, tend to be antiepileptics, okay? Because again, we're going to find when we get into the neurology section next is like those are meant to really kind of work with the circuitry of the brain to try to slow things down. And so this is essentially what we're doing here as well. So you're going to find a lot of overlaps. I'm going to talk about the antiepileptics briefly here. We'll get into more detail, and then when we get into the neurology section coming up next, I believe. Okay. Anyway, so again, look out for other causes for these manic symptoms. Could be associated with drug exposure. So if you have someone who's like having active hallucinations and they're tachycardic, hypertensive, pupils are dilated, like these are things you can look for to see like maybe something else is going on here, right? Maybe they have an infection, maybe they have drug exposure, etc. So lots of different things that could be associated with this. And if they say steroids, why do you think steroids? And they can cause a lot of mood alterations from the corticosteroid standpoint, but what about like, say, androgens, for instance? What do you hear about like androgens?
Aggression.
Yeah, aggression, like roid rage, right? You ever heard of roid rage? That's kind of what they're kind of thinking about with that. So again, look to see what the medication history is, look to see what the other history is to see if something else is going on. Anyway, so our goal is, and again, just like with a lot of other disease states, they can have sort of exacerbations of their bipolar disorder. They can have exacerbation of these manic episodes. In some cases, you're dealing with acute treatment of that to try to kind of knock them down a little bit, to try to get them sedated so that way they're not a danger to themselves or others. In other cases, we're more on kind of more maintenance sort of therapy, okay? And we'll look at the different medications for that as we go forward. And then obviously if we can get rid of other stressors or things that may be exacerbating their symptoms, things like alcohol and stimulants and whatnot, that's going to be very much beneficial in the long run as well. So therapy is going to be very individualized. Some people respond very well to one type of therapy. Some respond terribly to the same therapy. A lot of times side effects are going to be the thing that limit what drugs you can use. So we'll kind of look at those. And again, trying to pick the right drug for a patient may be dictated based off the side effects they experience. So anyway, the first drug we have is lithium. If you notice here, just like cocaine used to be in Coca-Cola, we have 7-Up actually used to contain lithium. So it actually was pretty good for your mood. However, you did see some toxicity associated with that. But it's been around for a good long time, actually probably since Earth has been around because it's just a metal, right? So, and one thing to note here is that it works, to the body, it looks very similar to sodium. So whenever your body's in a state where it wants to get rid of sodium, it's going to get rid of lithium. whenever it's in a case where it wants to hold on to sodium, it wants to hold on to lithium as well. Because again, if you look at them on the periodic table, they're actually very close to one another, right? They're kind of neighbors in that same column. Okay. Anyway, so from that standpoint, it's very well absorbed, just like sodium can be. It's a very small ion. Do you think this crosses the blood-brain barrier particularly easy? And no, it's a metal, right? It's got a positive charge on it, right? As soon as it goes into solution, it breaks up into its constituent components. Lithium positive, it's a cation, has a hard time crossing over. Once it crosses over, though, then it likes to stick around there for a while too, and that can lead to a lot of the toxicities we're going to see with this on a more chronic sort of basis here. Okay, but again, it's entirely renally eliminated. So if you have poor kidney function, you're going to hold on to lithium, and you're going to see some issues. This means it's also very dependent on the drug interactions that come about that can affect the levels as well, and we'll look at those in a few minutes as well. It will eventually. It doesn't like to initially because it has that positive charge, but again, eventually it can cross over. It just takes time. Yeah. So still considered first line by a lot of people, but there is a fairly narrow safety margin with this drug here. You have to really keep it within certain levels. I'm not going to have you memorize specifically what the level is, but again, be able to interpret it if I put that on an exam, right? So again, if I say, I'll give you the normal level, what the patient's level is, and you have to make some interpretations off of that. But it's very, very important to make sure you keep it within this range because you see a lot of CNS toxicity that can happen once you get above that. And again, when I think about like the drugs that like really kind of perk up my sphincter tone when I hear of like dangerous drugs in terms of overdose, lithium is one of them, right? TCAs are one of them. Aspirin's one of them. Lithium's another one of them, right? Very dangerous in overdose, very dangerous. And again, these patients may be prone to overdosing, right? We always talk about the sphincter tone as far as like on a rating scale of like, you know, if I see like an SSRI overdose, it's like a 3 or 4. It's not bad. You know, if I see like a late presenting Tylenol, maybe like a 6 or 7. I see like a TCA overdose, I'm like an 11. Like it's just, it's not good. Like, this patient's gonna die. Like, let's do something real soon. But anyway, other things you're going to find, and again, I have a typo here, but abrupt discontinuation of any of these medications can actually lead to a relapse, not remission. I'll make that correction there. But basically that means is that when you have these patients that go off their medications cold turkey, because again, they feel like they don't need any treatment, they can sometimes have exacerbation, and that's what ends them up in the ER usually, where they're very aggressive. They need a lot of medications to try to chemically sort of sedate them in a lot of cases there, right? Because again, anytime you need to put someone in restraints, whether it be chemical or physical, like you need to really take that very seriously, because again, usually you're doing that against their will, and so sometimes you have to do things like Baker Act the patients and things like that. You guys familiar with Baker Acts? What is that?
So they have to stay against their will.
Yep, so we're holding them against their will. What's the time frame? 72 hours. Who can Baker Act people? Physicians can. Police officers. Mental health counselors can do it as well, right? So those are kind of the big ones, and who can clear it? Yeah, you usually need to be a psychiatrist or someone with that kind of background that can clear it, right? And again, they need to be medically clear before that 72 hours sort of kicks in. It's like we'll have patients who we'll end up treating initially, say for 4 or 5 days until they're kind of out of the woods as far as medically speaking, once they're stabilized, and then we can kind of put the 72-hour clock on that, right? So he has a TCA overdose or something like that. Anyway, but just know that these medications, if they go off in cold turkey, they're going to probably have relapse of their symptoms, and that's when things can get pretty hairy for them. So a lot of patients are going to get side effects with lithium, which is, again, why a lot of people don't like it and a lot of people don't stay on it for very long. And you're going to see that in a lot of cases it can be related to peak dose effects. So if I take like an immediate release product and I get very high levels, that can sometimes lead to a lot of the GI toxicity you see with this. Again, when I say an osmotic diarrhea, it makes sense because it's an electrolyte, right? So again, if I have a high concentration of those electrolytes, the GI tract, that can draw water in and cause the diarrhea there, okay? Other things you're going to see, you can see things like polydipsia, nocturia, because again, that high sort of that salt load, so to speak, not sodium, but a salt in terms of lithium, tends to cause that osmolarity to go up, and that's going to cause that reflex and your ADH levels going, causing you to drink, right? So that's typically things you'll see with that. The chronic effects are also pretty problematic in the long term. This is when that lithium takes a while to cross over into the CNS. This is when you start to see these develop here. Tremor is a very common thing. Up to 50% of patients will develop kind of a fine hand sort of tremor associated with that. Sometimes we can give beta blockers that can actually help to prevent that, which can be useful. Or if we use like a long-acting sort of effect drug, so that way you don't get those peak dose effects, but kind of a nice long-acting kind of plateau. So that's one thing you're going to see. Other things include nephrogenic diabetes insipidus. What is that?
Prevents the kidney.
It prevents the reabsorption of water in the kidneys. And so what do you think happens? You're going to be peeing a lot, right? So again, this is one of those cases where the kidneys are not responding to the ADH you're actually sending out, right? So again, there's what we call a central diabetes insipidus, there's a nephrogenic. Nephrogenic means the kidneys are not responding to the ADH that your brain is sending out. If it was more central, it would mean your brain's not sending out the ADH in the first place, right? Anyway, so you'd expect to see a lot of polyuria associated with this. You can see hyponatremia associated with this, potentially a lot of dehydration. Interestingly enough, you can actually treat it with a diuretic. And think like, why in the heck would they treat diabetes insipidus or have polyuria with a diuretic? It gets a little counterintuitive, but basically by putting the kidneys, when they have that diuretic effect around, they kind of sense, like, oh, wait a second, I need to hold on to more sodium here. They tend to get better at activating things like the renin-angiotensin system, etc., and that helps to kind of re-regulate things a little bit. So sometimes you'll see that. Obviously, if a patient had diabetes insipidus due to lithium, what could you do to help treat that? Get them off of lithium, right? So again, if you find a patient who has that, develops that, it may either be an issue of dose, but more often than not, you're going to change the drug anyway, right? Nephrotoxicity, you can see hypothyroidism. Lithium actually can interfere with hormone synthesis. Again, I don't know what the full mechanism for that one, but what ion do you normally need to produce thyroid hormone? Iodine. Yeah, iodine is the one you actually need there, right? Anyway, so just know that hypothyroidism is something you can see with that as well. And what are some symptoms of hypothyroidism? Weight gain. How's their energy levels? Like some of you guys look like you're all hypothyroid when you walk in and you have to listen to my lecture, right? So again, what can that manifest, or what can that kind of masquerade as well? Patients who are bipolar, depression, right? So again, the question is, well, are their depression symptoms getting worse, or is there hypothyroidism starting to act up due to the lithium I'm giving them? So sometimes it can be multifactorial, right? Other things, you can see some cardiac changes here. There can be some dermatologic effects, like acne can develop from this as well, weight gain, slurred speech. So again, because a lot of those chronic effects, this is why a lot of patients end up getting off of it eventually. Now, as far as overdose goes, there's kind of a couple of different ways that this can happen. It can either be acute, where they take all their medication at once, which can lead to, kind of one sort of clinical picture, or it can be more of a chronic issue, right? Where again, they're slowly building up levels over time. Which one do you think is more dangerous? The chronic ones are actually a lot more dangerous because they've had time to build up those CNS levels pretty significantly, right? So again, when I measured the blood level, that can be kind of a surrogate for what's in the brain, but oftentimes what you're going to find is it has that distribution phase, right? It takes a while for that to even occur. But basically what you find is that once they have those kind of chronic overdoses, and this happens with patients like renal dysfunction, or if you put them on a medication where it interferes with it and causes levels to go up, this is where you come into that chronic toxicity, because they usually manifest things like seizures, and it can be very difficult to treat. So anyway. So any sort of interaction that is going to cause your body to hold on to more sodium is going to cause you to hold on to more lithium. Okay. If I had someone who overdosed on lithium, how do you think I could treat that based off of that mantra? And give a whole bunch of saline. Actually, yeah, that's what we can do. We actually put them on high rates of normal saline drips, and that puts the kidneys into a salt excretion sort of state, and so it'll cause that sodium, that lithium to actually go out. It's one of the best ways we can treat that. But anyway, so if you're dehydrated, if you have a sodium restriction, if you've been vomiting, heart failure, cirrhosis, any of those things can cause the drug to accumulate, right? So again, the longer it's accumulating, more of it can get into the CNS and cause those toxicities there. Other things you'd expect to see. If you have anything that's going to be interacting with the ability for the kidneys to get rid of that lithium, so say for instance I give a diuretic, right? We already mentioned with diabetes insipidus, giving a diuretic helps to cause the kidneys to go into a salt retentive sort of state. That's the same thing that's going to happen here, right? So those levels are going to go up. Even though you think you just pee it out, you actually end up causing levels to go up. Also as well, the diuretic, what happens to your volume status? It's going to go down, you're going to get dehydrated, that's going to cause it to get more concentrated, right? So it'll cause levels to go up as well. How do you think NSAIDs cause levels of lithium to go up? The afferent constriction of that arteriole, right? So afferent arterial constriction is going to happen because you lost those prostaglandins. So NSAIDs will cause levels to go up. ACE inhibitors are working on the efferent side. It's going to cause the same thing to happen. So very often I'll find patients who will come into the ER for chronic lithium toxicity, and again, usually it's no fault of their own necessarily, or at least we're very unwitting, because they had ache or pain or something. They took ibuprofen for it, right? Or someone put them on, enalapril for their hypertension. All of a sudden, they're holding on to more lithium, and so I see that fairly commonly. And again, who often is going to be prescribing lithium for these patients? Maybe their psychiatrist, right? And then if you're their primary provider, and you weren't aware of the fact they were seeing someone else for that, and then you prescribe something like an NSAID or an enalapril or an ACE inhibitor, you can cause that interaction without really knowing. So again, it's very important to make sure those communications are happening and you know full well what your patient's actually on, right? So it's a very effective drug for bipolar disorder, but it's kind of fraught with a lot of issues, right? And again, you have to do that therapeutic drug monitoring, and just kind of a big kind of pain in the butt. So instead, what they've been trying to use are anticonvulsants for bipolar disorder as well. One of the more common ones you're going to run into is Valproic Acid. There's a couple of different forms out there. There's Depakote, Depacon, Depacon, all kinds of different ones, brand names for it, for the different formulations, whether they're immediate release, extended release, liquid, whatever the case may be, right? But originally used as an anticonvulsant, very good as an anticonvulsant there, but we also realize it's also a very good mood stabilizer. And that's kind of the broad term we'll use for things like lithium and valproic acid and carbamazepine for use in bipolar disorder. They're mood stabilizers. So again, the idea is they prevent you from going from vacillating from the manic phases to the depressive phases, kind of just stabilize everything out and hopefully kind of keep you right there in the middle. Okay. Anyway, we're not really sure the full mechanism for valproic acid. It has some effects at, calcium at the neurons, maybe has some effect on GABA. And what do we know about GABA? What does that normally do? Yeah, mainly inhibitory, and we'll talk much more about that in the neurology section coming up, so kind of keep this in the back of your mind. But one thing you will note is that by using a different mechanism for bipolar disorder, you do get some synergy there. So you may find some patients who are on different medications, maybe on lithium and valproic acid potentially, and by using that combination, you get kind of better effects than just either one by itself, right? So big things you're going to see with valproic acid, some GI upset, but you're typically going to find kind of seeing a slowing, right? So you can see ataxia, you can see gait disturbances. The other big thing you'll find with valproic acid is the hepatotoxicity. Okay, so be aware of that. You can see their LFTs go up. You have to monitor for that. You can also see their ammonia go up, right? So hyperammonemia is a thing you can see with valproic acid you want to at least be aware of. I actually had one patient who he's a teenager. He was taking valproic acid for bipolar disorder. He was actually in school, and they noticed at school that he was acting kind of loopy, and he just wasn't acting right. And they were like, oh, he must be taking some drugs or something. Like, he's got to be on something. Or he's drunk or something, right? So they ended up bringing him into the ER. We were trying to look at his stuff, and his valproic acid level was totally normal. His alcohol was negative. He had no other signs or obvious history that he could have been exposed to something else. And so we were thinking about, what the heck's going on here? And I was like, wait a second, let's check an ammonia level. And sure enough, we checked an ammonia, and it came back up high. And again, hyperammonemia is something you normally see like in liver patients anyway, so that's why you can kind of think about this with valproic acid. But we were able to give them an antidote for that. It's actually carnitine. Basically, valproic acid causes a carnitine deficiency, and so we kind of replaced that, and all of a sudden ammonia levels went down, and the kid was right as rain. Okay. Carnitine. Yeah, levocarnitine is the drug we'll give for that. You can find it as like an herbal supplement, but we give a medicinal product for that.
You don't treat it the same way as you would for like hepatic encephalopathy with like lactulose?
Lactulose could potentially get rid of it, but here, if we can just deal with the problem is that basically that carnitine deficiency leaves it so that your liver can't process the ammonia. So if we can fix that, that's going to be much more effective than giving the lactulose, right? And so at that point, we realized, well, the kid's therapeutic, but he's still developing this hyperammonemia. You had two options. You could either take him off the drug altogether, which of course we're not doing in the ER, right? We're probably not going to give it to him while he's there, but or you could potentially supplement him with levocarnitine chronically. So again, giving a drug to counteract the effects of another drug, which is not ideal, but if he was really well stable on that valproic acid and nothing else works, then that's sometimes what you have to do, right? So again, kind of weighing your options there can be very difficult depending on kind of what they're manifesting. Okay. Anyway, and again, sometimes when kids are like, no, I haven't done any drugs, sometimes they actually tell the truth, and that kid was actually telling the truth when he was actually coherent enough to tell you something. Anyway, but this is another one we'll do therapeutic drug monitoring on. So the range can be pretty wide depending on what your indication is, but anywhere from 50 to 125, usually pretty good for bipolar disorder. Okay. Up next, we have carbamazepine. This is Tegretol. This is actually kind of structurally similar to the TCAs we looked at before, which you're all very familiar with, unless you've dumped all that information just in the past few minutes. But for its mechanism on mania, we're not really fully sure about that, but one thing that it does do in the treatment for seizures is actually block sodium channels. And again, you guys remember the action potential, all the phases of an action potential with sodium influx and potassium efflux and all that good stuff. We're going to cover it again when we get to neurology. But basically, when I block sodium channels, I'm blocking action potentials from being propagated. Okay, so again, slowing everything down by preventing those signals from being sent. And so maybe this is why it kind of works for bipolar disorder. We'll talk about it more in the seizure section later on. But this is actually a pretty good one to use in patients who may be refractory to lithium, or maybe they're not good candidates for that due to either kidney dysfunction or something else. And so, again, this is another one we do therapeutic drug monitoring on. The range of 4 to 12 usually is pretty good for most patients. Big things you're going to note with this as well is that, yes, it's going to cause mental slowing. That's pretty common with all these antiepileptics. But the unique sort of thing you find with carbamazepine is it actually causes something called SIADH, which is a syndrome of inappropriate antidiuretic hormone secretion. So what do you think happens with that? You have too much ADH, which does what? You don't pee enough, right? Because you're going to hold on, because you put more of those aquaporin channels into the collecting ducts. You hold on to more fluid. What?
Serum osmolarity goes down.
Yep, serum
osmolarity goes up.
Yep, and then what could happen to your, say, for instance, sodium level? Decrease, yeah. So this is actually what happens. You end up developing what we call euvolemic hyponatremia, because ultimately the patient's able to deal with some of that extra fluid, so they don't get really like edematous like you would expect to see for someone who had like acute renal failure, but you see a euvolemic, so again, volume status is normal, hyponatremia associated with that, okay? We'll find one of the cousins of carbamazepine is even more notorious for causing that, but sodium is definitely something you want to watch for with carbamazepine, okay? How do I get a sodium level? What would I order? Either a CMP, which is a complete metabolic panel, or a BMP would be even easier. If I just needed the sodium, I could do that, right? Be a little bit easier just to get a Chem 7. Okay. You guys have covered like your fish bones and stuff for Chem 7s. You guys know that pretty well. So if I were to draw it out, and again, just because I'm going on tangents here, you guys call them the fish bones. So to draw that out, what's in? Sorry, what's in this box here? Yeah, sodium's there. What's in this box? Potassium. What about this box? Chloride goes in there, right? Your CO2, your bicarb, right? BUN. Don't say bun, say BUN. You sound silly. What about this box? Serum creatinine, and then glucose. I'm serious about that. I've seen people call it a bun before, and like you get made fun of mercilessly in the hospital. It's just we just don't call it that. It spells bun, hot cross bun. I don't know. Hot cross BUN. I don't know. But yeah, just say BUN. No worries, no worries. See, this is good because you learn this stuff in school where this is a safe environment. We're allowed to fail here, right? Yeah. There you go. That's the main goal, right? Because even when people say like, "Who taught you this stuff?" I don't want my name to be directed to mud, right? And they'll be like, "Oh, that guy again." Oh. Anyway, okay. So big things to note with carbamazepine as well is there's a lot of pharmacokinetic interactions here. So this actually induces CYP3A4. It's problematic if they're on, say, for instance, other anticonvulsants, maybe substrates here, if you're on oral contraception. Because, again, what do we say about the decision-making of people in manic episodes? Not great, right? So, again, if they're being, say, for instance, promiscuous, and their estrogen levels for the contraceptives are down, what could happen? You can get pregnant, right? So, again, that could be a problem there. So you want to be cognizant of that. What could I do to get around that? Anyone know? Intrauterine device, yes, condoms are great. But, again, decision-making, it's not great there. So what if I did something where they don't have to make the decision, right? So you could do something like an implantable, you could do an implantable contraceptive, intrauterine device. We'll talk about those in the OB-GYN section later on, but start to think about things like that, right? Things like depot shots and whatnot. Anyway, other things you can note as well is like valproic acid can actually displace carbamazepine from serum proteins. What happens when that occurs? You have more physiologically active drugs. Even though the level may look normal, say it's a level of 10, but they're having a lot of extra side effects, it could be related to a protein binding interaction from where that drug is free and can interact with those sodium channels, right? Oxcarbazepine or trileptal is a cousin of carbamazepine, and this one you don't do levels for, but it's even more known for causing SIADH. So again, you got to monitor sodium levels for these patients here if they're having anything. And again, one of the things, what do you see? What are some of the manifestations of hyponatremia? Confusion, and what do we say about these drugs? Their effect on the CNS. They can cause confusion too, right? So again, a lot of the side effects we don't know necessarily. Is it just due to the mental slowing that's occurring based on the anti-epileptic properties, or is it because they're hyponatremic? It can be very difficult to tell, right? Unless you did a BMP and you can get those levels, right? Anyways, just something to keep in the back of your mind. So adverse effects are very, very similar to carbamazepine because they do very similar actions here, just more SADH. It's more likely to see hyponatremia. And then this does induce CYP3A4 as well, and can actually inhibit CYP2C19. That one's not quite so important, but the induction of 3A4, very, very important. Up next, we have lamotrigine or Lamictal. This is another pretty common one I see. I probably see most commonly either Valproic Acid or Lamictal being used for mood stabilization nowadays. And so this one, again, is working to block sodium channels, but it can also inhibit glutamate release. And glutamate normally does what? very excitatory, right? So again, if you think about GABA being main inhibitory neurotransmitter, glutamate's a main excitatory neurotransmitter, right? So by inhibiting glutamate, again, you're slowing things down overall, right? Very good mood stabilizing effects. Actually has a little bit of some antidepressant effects as well, which could be beneficial for these patients. But just know that whenever you start to combine these drugs together, valproic acid and lamotrigine, you got to be really careful with those, because you can actually find that valproic acid can inhibit the clearance of lamotrigine, make it so you have to actually half your dose before you even start it. So make sure you're looking at those interactions before you add on anything new to one of these psych regimens, right? Because they can be very fraught with drug interactions there. The big thing to note about lamotrigine, you're going to find with a lot of the anti-epileptics that, dermatologic reactions are fairly common. This is a big one, though. So anytime you have any like new rashes or blisters or anything like that that starts with lamotrigine, they need to stop the med and get evaluated pretty quick. Okay, especially if there's anything severe like blisters forming. Again, that can either be on the skin or it can be like on the mucous membranes. Things like that can be as well. So again, if you had someone who started to develop like stomatitis during treatment with lamotrigine, like, those are all really serious things, because that could turn into Stevens-Johnson syndrome or toxic epidermal necrolysis, right? SJS or 10. Either one of those can be very, very bad if they're not caught early, and can be potentially fatal. So again, just be aware of that. Some patients, are going to get some rash. Rash isn't necessarily going to stop you from taking the med ever again, but it's probably not a good sign. You probably want to at least show you they're more likely to develop a reaction. Probably just take them off of it overall. Okay, so make sure you educate on that. Okay, so those are the main mood stabilizers we can use. We're starting to see we can actually use antipsychotics for bipolar disorder as well. We'll talk about schizophrenia more specifically here right now. So looking at the antipsychotics, we see we have two different options here. We have the first generation agents, we have our second generation agents. Again, right now I'm talking about them in terms of bipolar disorder. We're going to get much more into detail on them when we get to the schizophrenia section in just a few minutes here. But the big thing to know with the first generation agents, they work by blocking dopamine, blocking D2 receptors specifically. Okay, you're gonna find the second generation agents, they block some dopamine, but they also block serotonin, these 2A receptors, and that actually helps with some of the different symptoms we're gonna see with schizophrenia in a few minutes. But typically what you're gonna find is that if you're having someone having an acute manic episode and they are a danger to themselves or having to be restrained physically, our antipsychotics are very good because they're very sedating, and they can help to get that patient kind of under control, right? I'll never forget this one patient who's in the ER, and he was being very verbally aggressive. He was, we had the big open kind of ER, right? So you had probably 30, 40 beds, like all kind of open, so you could hear everything that was going on, right? For privacy, you just pulled a little paper curtain, basically, and that was your privacy, right? So anyway, this guy was screaming, hollering. He was, not physically violent with anyone yet, but it was definitely heading that direction, right? So they're just trying to figure out, like, we got to do something with this guy. I just remember him going, "I'm an atom bomb. I'm going to go off in any minute now." And we're just like, oh, Jesus. We had a bunch of security there. It was just bad, right? So anyway, so all of a sudden, like, you hear him, he's like, "I'm about to go off," and there's... and I hear a ton of snoring. Basically, we finally got an IM shot of an antipsychotic into him, and we're able to, like, knock him out, basically, right there. So chemical sedation was very powerful, able to get that guy under control. That way you can finally get labs done, you get an IV started, you can do all those other things you need to do with the guy. But these are very, very handy agents. And so when we talk about things like Haldol, well, vitamin H, it's a very good one. It's a very good one. Talk about vitamin A and vitamin H in the ER. It's Ativan, which is benzodiazepine, and Haldol. All right, those can be a very good combination. Nowadays, we're starting to move away from Haldol a little bit and seeing more of these second generation agents. So if you ever see like Geodon or Zyprexa or things like that being used IM, that's usually for like an acute manic sort of episode or like acute schizophrenic kind of episode where you need to get someone knocked out pretty quick, right? And I say knock out, we're not like hitting them over the head with the club necessarily, but like chemically, that's essentially what we're doing, right? So you need them to be sedate now, right? So anyway, so very good for that those kind of acute phases. Sometimes we'll add on like a second generation agent in addition to some of the mood stabilizers, and you do see a little bit of synergy there. However, we do know that with chronic use of a lot of these antipsychotics, is you're going to find there's a lot of metabolic issues that pop up, right? So you're going to find hyperlipidemia, hyperglycemia, increased blood pressure. So there's a lot of metabolic issues that you have to monitor for as well, okay? So just be aware of that. We'll talk much more about those in detail in a little bit. So again, start off with a mood stabilizing agent. And again, it depends on kind of where they're at when they're coming in. Are they in a more of a depressive phase or are they more of a manic phase? Obviously, if they're more manic, you got to deal with that first, right? So again, if they're acutely a danger to themselves or others, that's where you're going to be using more sedating sort of agents here. But if they come in, they're just in a kind of a manic episode and you're just trying to stabilize them out. Lithium's a good one. Carbamazepine's a good one. Lamotrigine, any of those are totally fine to try to help kind of get them under control initially. If they're having a lot of anxiety, insomnia, this is where things like benzodiazepines benzodiazepines can be very useful. We'll talk more about those in the anxiety sections and in terms of neurology when we get into the antiepileptics. And then again, for more severe episodes, you may need two or more agents potentially. Okay, just be aware of that. Usually if you're mixing different drugs together, it's good if you use like lithium plus an anticonvulsant or an anticonvulsant plus a second generation agent. You're using different enough mechanisms where you get a little bit better synergy there. Okay, so again, if I were to ask you, hey, what's another good agent to add on for this patient? I said, they're already on carbamazepine. What would you want to add on? Like lithium might be a good option. A second generation agent we'll talk about might be a good option. Valproic acid. Oxcarbazepine would not be a good option because they're actually doing the same thing, right? So again, you wouldn't see any synergy with that. Okay. All right, so any questions on bipolar disorder? Okay. Moving on, let's talk about the antipsychotics more in detail here. Okay, so have you guys covered schizophrenia yet? Okay, so I'm going to go over a little bit of the pathophysiology here. There's three main types of symptoms you're going to find when you're dealing with schizophrenia. We're going to talk about the positive symptoms, we're going to talk about the negative symptoms, and the cognitive symptoms. Okay, positive symptoms. Anyone know what that means? Yeah, so stuff is there that should not be there. So for instance, if they're having auditory hallucinations, normally you should not have auditory hallucinations. That's a positive symptom, okay? If they're having delusions of grandeur, like some of your teachers may have, me included, that is something that should not be there. That is a positive symptom, right? Paranoia, etc. Those are positive symptoms, okay? Negative symptoms are things that should be there but are not there. So if you don't get any pleasure out of anything anymore, right? What do you call that? Anhedonia, right? Anhedonia is where you don't find pleasure in things. If you have avolition, you don't have any motivation to do anything. Those are negative symptoms, right? So typically, and again, some patients may be more predominantly showing the positive symptoms and maybe more showing the negative symptoms. Depends on kind of where they're at in their disease state. But there's also the cognitive symptoms. Those are usually things like mental slowing and may have impaired ability to make decisions or to critically think, things like that. Anyway, the thing we're thinking about why this occurs is mainly due to dopamine dysregulation. Either we have too much dopamine in certain areas or too little dopamine in other areas, okay? And so one of the things we're going to find is that the dopamine hyperactivity is what we think is kind of related to the positive symptoms, okay? When you have the hallucinations, when you have the acute paranoia, things like that, those are what we think is dopamine hyperactivity. The negative symptoms and the cognitive stuff, we think that's more of a frontal sort of issue here, and we think that's mainly due to dopamine underactivity up in the frontal cortex. We also know that serotonin has a very good inhibitory sort of effect on dopamine there as well. And I only mention all of this because the medications we're going to use are going to be targeting those specific mechanisms. They're either going to be shooting for blocking dopamine activity or they're going to be shooting for inhibiting serotonin activity. Okay, I'll show you that delineation here in just a little bit. Now again, we will talk about it later, but what disease state is the hallmark is dopamine underactivity? Parkinson's, right? So one of the things you're going to see is that whenever you're giving a drug that's blocking dopamine, you're going to be inducing symptoms that look a lot like Parkinson's, okay? We're going to call this extrapyramidal side effects. Yeah, you're going to see things like tremor. You can see things like dystonias. You can see like the muscles kind of tense up. You can see things like shuffling gait. You have a hard time initiating movements, essentially, right? So you're going to see some bleed over effects there. So just kind of keep that in the back of your mind. Anyway, so as I mentioned, they oftentimes can kind of lose touch with reality, kind of create this kind of false reality for themselves, and that's where you see things like delusions and hallucinations. Those are more of those positive symptoms there, right? Their affect, though, affect is usually pretty flat for the most part, and that's part of the negative sort of symptoms there. So could be pretty flat, could be sort of inappropriate, they may not be responding appropriately to questions and things like that, or it could be kind of labile, right? So especially if they're having something telling them to, even though they're trying to start an IV on the patient to give them medications to make them feel better, they're thinking they're trying to give you poison, right? They're going to try to kill you. Those are, sometimes it can lead to some pretty violent reactions with some of these patients. So again, depending on where they're at, you may need things that are going to be like really heavy dose stuff to like really knock them down, or sometimes you're going to be giving them things more for the maintenance sort of phase there. We'll look at the difference there. Anyway, compliance is going to be awful with these patients, right? Because again, if they're being told, hey, you don't need to take these medications, you're fine, you don't have any problems, they're not going to take it, right? So again, they oftentimes lose a lot of function, they can't keep a job potentially, hygiene goes out the window. You find a lot of these things can kind of snowball on themselves, and so compliance is going to be bad. The problem is that when they have these relapses, they ultimately end up hospitalized or end up Baker acted and things like that, and so it can become very difficult, from that standpoint. So again, things like social work and things like that are super, super important for these patients as well. Also, a lot of substance abuse associated with this, either illicit or illicit, so just be aware of that as well. Anyway, and so again, you kind of see how these different symptoms kind of fall in, where they fall into the different categories here. The positive, again, things that are there that should not be there. Negative, things that should be there that are not there. You know what alogia is? Can't come up with words for things, right? Sometimes I develop alogia when I'm up here talking to you guys, right? Volition, again, they just don't have any motivation to do things like that. And then the cognitive effects as well. Okay. And so again, we're going to find either our agents are going to be mainly focused on dealing with the positive symptoms, or they're going to be mainly focused on the negative and cognitive, and they'll have a little bit of positive activity as well, but those are the other main things we'll focus on as well. Okay, get to the medications. So our goals, here we're going to find that pharmacotherapy is going to be key. Obviously, you know, things like behavioral therapy and things like that can be synergistic here, but you got to have drugs on board. They tend to find if you start out early in managing these patients, especially during the first 5 years or so, they tend to kind of retain function for longer, which is good. Problem is, like, sometimes it may be difficult to identify these patients early on, so you may not catch them until they actually have, you know, kind of a really bad episode, and then you're kind of behind the 8 ball from that standpoint. Does anyone ever see that movie, A Beautiful Mind? Yeah, you should watch that. It's actually a very good movie, and it looks at, you know, the patient developing schizophrenia and a lot of the medications actually used to treat that, and it's actually good to remember a lot of the side effects that can develop from those. So again, go check out that movie if you have a chance. I know you guys have all the time in the world to watch movies, but it's good for say it's actually for study purposes, right? Anyway. And again, therapy really has to be individualized. Not any one drug is going to work perfect for a patient. Be aware that side effects often are going to dictate what you're going to use as well. Okay. So our goals here is, one, we want to, you know, try to minimize side effects if possible. So we'll look at some ways we can do that, and then try to decrease that rehospitalization, right? Decrease their need to actually have to come in, get evaluated, because again, I can kind of throw them for a loop from a social standpoint. If, you know, they had a job, maybe they lose their job, you know, a lot of different things like that, right? Anyway, so our first generation antipsychotics, we mentioned they are mainly working to block the activity of dopamine. That's their main action here for schizophrenia. By blocking D2 receptors, they're going to decrease those positive symptoms. If you're curious where that is, actually in the nucleus accumbens is mainly where that's going to be working at. I'll show you a diagram of that a little bit later. But the other thing, as we mentioned, is that, you know, you see dopamine underactivity up in the frontal cortex. That's where you got a lot of those negative and those cognitive symptoms for. Well, if I block dopamine everywhere, yeah, it'll deal with those positive symptoms. What do you think happens to the negative and the cognitive effects? They actually get worse, right? And that's actually one of the things you'll see is, like, when you give these patients these antipsychotics, as I mentioned, if you have someone who's like acutely violent, I need to knock them down. Like, how else going to do it, right? And again, you're going to find, even if they're awake, they're just going to be like just zonked out, and it's just like that. And that's good in some cases, right? Because I can get them evaluated, I can get the IVs, I can do labs, meds, whatever I need to do. But that's not great if you need to, like, you know, be functional in society, right? So typically what you find is those first generation agents, very good for positive symptoms, and for a while that's all we had, but they're not great for negative, not great for cognitive symptoms. Typically going to worsen those. Other things you're going to see, when you think about dopamine, you have to think about a few seesaw effects that occur with dopamine. One of the things you find is that with dopamine, as its activity goes down, prolactin levels actually go up. Okay, so less dopamine means more prolactin. That can lead to things like gynecomastia. That can also lead to things like menstrual irregularities, right? Can lead to decreased fertility, things like that. So just know that hyperprolactinemia is a consequence of blocking dopamine actions, okay? Another thing you're going to find, by blocking dopamine, you increase the activity of acetylcholine. Acetylcholine can lead to things like tremor, can lead to things like dystonias, and we're going to find some of the drugs we actually use to treat those side effects are actually going to be anticholinergics. We'll look at that in a second. And the other big thing here is going to be the extrapyramidal side effects. So when you hear about first generation agents, you hear about EPS, that's what we're actually talking about, right? It's not ESP. They don't become psychic all of a sudden. But it's EPS, the extrapyramidal side effect. And this is essentially the Parkinson-like effects I mentioned here, right? Because again, in Parkinson's, you're losing dopaminergic neurons. With these agents, you're actually blocking the activity of dopamine such that you're kind of causing the same thing, essentially, right? And so this is where you can develop things like motor rigidity, tremor, catatonia, where they're basically just not really able to make movements occur. You know, they can't, you know, voluntary movements. Also, is where you can see acute dystonias, right? And so, one actually a good story about this is we had a group of patients that came as actually a family. It was a mom, a dad, and a teenage son. And they, you know, the family that abused drugs together typically stays together. And so they all three came in together. And what they thought they were buying off the street was, they thought it was Valium, right? Valium is the brand name for diazepam. You know, when you look at a pill, every pill has a pretty unique identifier on it, right? Well, this one had like a brand on it, and it actually was very similar to another pill called haloperidol, or Haldol. So when they bought it off the street, they thought they were getting diazepam, which is a muscle relaxant, and instead what they got was haloperidol. And when they came in with these acute dystonias where they found that they were very contracted. Oftentimes you'll find either like facial manifestation where their tongues will be sticking out, the jaws will clench up, upper limbs can become very contracted, and so it was interesting because you had someone who they thought they were abusing a muscle relaxant, and they come in, they're having dystonias instead. With some ways to treat that, but those are big things you can find. And again, the more potent it is at blocking dopamine, the more likely you are to see those effects. And I'll talk about 2 drugs in particular that are very high potency dopamine blockers. Haloperidol is actually one of them. Right? It's kind of the more common one you run into. Anyway, other things you're going to find, akathisia. Anyone know what akathisia is? Have I talked about that? Yeah, we talked about it a little bit when we were talking about the antidepressants. That's that kind of that just uncomfortable in your skin kind of feeling. You just got probably most of you have it right now, right? You're just I just got to get out of here. That's that kind of feeling. So there's a lot of pacing, shuffling feet. It's very common you see with that. And then tardive dyskinesia is a long-term effect of long-term dopamine blockade. This is something that once it occurs tends to be irreversible. Okay, so this is when all we had were first-generation agents. This was a known outcome, but we just knew that it was going to be something that happened long-term. But it's like either we have that or we have them not being treated. And so it was kind of a difficult decision to make with that. But basically what happens is the dopamine receptors actually get hypersensitized. And so you end up finding that, and again, you don't treat dystonias like you treat tardive dyskinesia, as we'll see here in a few minutes, but they can develop things like inappropriate muscle movements. They'll have kind of these repetitive sort of actions. They'll have like, lip smacking or like chewing kind of motions. And again, it's related mainly to the dose they're receiving and the duration of treatment. Okay, so if you ever see someone who's like constantly, or just look up some YouTube videos of tardive dyskinesia and you'll see what it looks like. And again, they have no control over it, and it's something that's never going to go away for a lot of them. And so they used to do things like drug holidays. You know what a drug holiday is? It's not where I go to Cancun and do a bunch of drugs, right? It's like a holiday where you go off of the drugs entirely, right? And so again, sometimes we do things like drug holidays, but that can lead to relapse of symptoms. It was very difficult to manage. So the benefit here is with our newer agents, they have very much less likely a chance to cause EPS, and they're have a low probability of causing tardive dyskinesia. So that's what we like about the second generation agents, as we'll see here in a few minutes. Anyway, other things you're going to find. First generation drugs tend to have a lot of other kind of ancillary effects, not really related to the dopamine antagonism. They can cause things like alpha-1 antagonism. What does that cause? Hypotension, right? Reflex tachycardia, right? You're going to find that they have a lot of antimuscarinic activity. What's that going to cause? Dry as a bone, hot as a match, red as a beet. You guys know it, right? And again, it's part of this repetition, right? Because I want you to know this stuff kind of just in the back of your mind, just know it, right? What does that do to heart rate? That's going to increase it as well, right? So again, you see the alpha-1 antagonism can lead to reflex tachycardia, have antimuscarinic activity. So sometimes you see these things kind of working in tandem. Now, actually, what you find is that the antimuscarinic activity is actually good in some respects, because when I said we block dopamine, what happens to acetylcholine activity? It goes up, right? So again, and that causes some of those extrapyramidal side effects we talked about. So it's actually good for the Parkinsonism from that respect, but not really good for the tardive dyskinesia. Actually can make it worse. And so what you find is that we'll find drugs that have very high potency D2 blockade. That's really all they do, essentially, right? And they're very likely to cause EPS. And then you're going to have some that are less potent, they have a lot more antimuscarinic activity, and that might actually be a little bit better for some of those EPS sort of effects. Actually, when you watch that movie, A Beautiful Mind, which I don't know if you're going to go home and do that, but one of the ones they put them on was Thorazine, was the brand name, was chlorpromazine, and that actually is one that has a lot of antimuscarinic activity. We'll talk about some of those other effects here in just a few minutes. Other things, they have a lot of histamine receptor blockades. So you have things like sedation and weight gain associated with this, right? Weight gain goes hand in hand with things like hyperglycemia and dyslipidemia, so a lot of metabolic effects. And then the cardiac effects as well can be notable, especially in overdose. Especially when I see a lot of these patients, when they overdose on these meds, you see a lot of QT prolongation, which can put you at risk for ripsaws, right? Sometimes you see sodium channel blockade, which will widen out your QRS, which can lead to ventricular arrhythmias. So just be aware of that, right? So normally, at therapeutic doses, you don't see a ton of cardiac effects, but certainly in overdose, you can run into some big issues there. The other really concerning thing to think about with dopamine receptor blocking drugs is NMS, or neuroleptic malignant syndrome. Neuroleptic is basically another term for the antipsychotics. We don't use too frequently anymore, but this name's still stuck with NMS. But again, the two big drugs that are going to cause this are the two that have the highest potency at blocking D2 receptors. It's fluphenazine and Haldol. Haloperidol. Very likely to cause that, but it could occur with any agent, right? So it's not just those two. Those two just had the highest propensity to do it. And so what you end up finding is that it can develop hyperthermia, you see some ultramental status, you see hypertension, you see some muscle rigidity. What else does that sound like? Serotonin syndrome actually sounds a lot like serotonin syndrome. They too look very similar to one another clinically. The big difference between these two, what do we talk about the increased muscle tone in serotonin syndrome? There's more in the lower limbs, right? And usually clonus is kind of the big thing you see with that. This is lead pipe rigidity. So it's kind of a classic sort of description of NMS. If you ever see that like on a board question, it says someone has lead pipe rigidity, think NMS, right? And basically the muscles are so tensed up they just cannot relax them. That can lead to overworking of the muscles, that can lead to muscle breakdown, that leads to acidosis, that leads to rhabdomyolysis, can lead to renal failure. It's not great. Okay. So just know that the high dopamine receptor blocking drugs are more likely to cause NMS. We'll talk about treatment for that a little bit later, okay? So here are the agents. There's a lot of first-generation antipsychotics here, right? The ones that I've highlighted in green are the ones that I want you to be familiar with for testing purposes, okay? These are more common ones. Again, some of these are really old-school drugs that like I've never even seen used clinically, but the ones I have here highlighted are definitely ones I certainly have seen. Bless you. So haloperidol, fluphenazine, these are the most likely cause things like NMS and EPS, based on their dopamine receptor blockade, and that is evidenced by looking at this chart over here, looking at the pluses. Now, do I want you to memorize, is it 4 pluses, 3 pluses, 2 pluses? No, but in broad terms, know which ones are the really high potency D2 blockers. And then when you look at something like chlorpromazine or thorazine, notice here, not a whole lot there, but a lot of the antimuscarinic activity, a lot of alpha-1 blockade, a lot of histamine blockade. Those are going to be the more predominant effects. So you're going to see more sedation, you're going to see more weight gain, you're going to see more dry mouth and constipation and things like that associated with the low potency agents, but you're not going to see as much EPS. You're not going to see as much of those Parkinson-like effects. Does that make sense? Okay. So anyway, so chlorpromazine, thyroidazine, prochlorperazine is actually a common one you actually find used for nausea and vomiting. We use that a lot for migraines. If you ever see that compazine, that's usually used for that. Doesn't mean they're psychotic, it just means they probably have a migraine and they're probably vomiting from it. Yeah, so those are the 5 big ones I probably would want you to know for testing purposes. You'll see some other ones that are out there, but just be aware of that. And actually, you know, it's interesting, just think about a case we had several years ago. We actually had a baby who probably like, I don't know, probably 8, 9 months old or something like that, and was having severe back arching. Anyone know what that's called when you have like severe back arching? A piece of the tonus. If you look up a piece of the tonus and Google, you'll find a classic painting that shows this guy like with a super arched back. Very, very painful. And so we had this baby that was developing this piece of tonus, and we're just like, what the heck's going on? The baby's screaming because it's in so much pain. EMS calls us initially, and we can hear the baby screaming in the background. It's awful, right? And you're just like, oh my gosh, what's going on with this kid? And so we got more of the history, and mom apparently had a huge history of psychiatric issues. And mom said, I just don't want to deal with this baby right now. Puts the kid on the floor, goes in the room, locks the door. Okay, so kid's crawling around doing what kids do. What do kids do? Get into stuff, right? So she gets into mom's meds. So now we have to ask, okay, well, what meds does mom actually have access to? And we're going through, and there's a big kind of mix-up between what EMS was communicating to us as far as like the name was, but we ended up finding out what it was actually a drug called Navaine or theothixine. And so what we were having is this kid was developing an acute dystonic reaction, which normally for adult patients, maybe, you know, a limb or two get affected here, but this is the whole baby's body got affected because it got a full adult dose of this stuff. And so what we did is actually give them the treatment for it, immediately fixed it, okay? And so just be aware when you see these things, like, you know, think about the dose the kid's receiving potentially, and you have like accidental ingestion like that, but we'll look at the treatment for that in just a minute. But that's what I want you to think about with these dopamine blocking drugs, is that dystonic reactions, the EPS you're going to see associated with them, and that's mainly the dopamine receptor blockade, okay? Anyway, this is another table which is good to compare. You'll find your atypicals are also on here, which we'll talk about those a little bit later on. But looking at your typical low potency, notice chlorpromazine, thyroidazine are on there, and then your typical high potency, haloperidol and fluphenazine are the big ones I want you to know here. And these are the side effects you can see associated with this more commonly, right? So for instance, looking at chlorpromazine, you see a lot of sedation, not so much on the EPS side of things, a lot of anticholinergic, orthostasis. What is the orthostasis caused by? The alpha blockade, right? You know, seizures, things like that. Typically, antipsychotics lower the seizure threshold, which makes it more easy to have a seizure. So just be aware of that potentially for patients, especially when they have overdoses. They're more likely to have seizures anyway because all the meds interacting. This is one that can lead to that. So again, good for review. I'm not going to ask you very specifically on a test. Did this say moderate or low, or very low, or did it say high? I don't care if you know that, but again, broad strokes. I want you to know, okay, high potency agents, this is what the side effects are more likely to cause. Low potency agents, more likely to cause these other side effects. Anyway, as I mentioned, first generation agents are very good for positive symptoms, but oftentimes the side effects will lead to discontinuation. and you need to select the agent based on the symptomatology. So as I mentioned, someone who's having an acute psychotic episode in the ER, they're acutely violent, I need to do something about those positive symptoms. That's where a high potency agent is going to be really good for that. Haldol, it's going to work great, right? We just call it B52 when you give it to them. You give them 5 of Haldol and give them 2 of Ativan, and they were asleep. So over here, B52, it's kind of an old school kind of term there. But anyway, so and again, if they're not really having all those positive symptoms, well, maybe something like a low potency agent is going to be okay, like chlorpromazine or something. But again, just be aware that every patient needs to be treated a little bit differently there, right? Let me just briefly go over the treatment real quick for the side effects here. For EPS, the problem is you're blocking dopamine, so you have too much acetylcholine activity. Well, let's block the acetylcholine activity. This is where our anticholinergics are going to come into play. So when we had that kid that had diabetes tonus, basically what we did was give them Benadryl. Benadryl is an anticholinergic. It's going to reverse those effects there, and then the kid immediately relaxed and was able to basically fell right asleep because again, Benadryl causes what side effects? Sedation, right? So yeah, so Benadryl works great for that. We'll see things like trihexyphenidyl or benztropine are also very good agents. Sometimes you'll see patients being treated in the ER for like an acute reaction. Sometimes patients will be on this kind of all the time just because they know they're more likely to have a reaction there, right? And again, more likely to see this with high potency agents like haloperidol, fluphenazine, okay? If that was failing, you could also use benzos. We'll talk more about benzos in the behavioral section or the anxiety section later on. But again, there's very good muscle relaxant sort of effects that can also be used as well. Tardive dyskinesia, you actually want to avoid anticholinergics. They'll actually make them worse. But the biggest thing you do is either just discontinue treatment. Probably the best thing is to switch them over to a second generation agent. And so you see less of this nowadays because most patients end up getting started on a second generation versus the first ones. So just be aware of that. But as I mentioned, like drug holidays are a good option as well to try to decrease the total body exposure over the course of years. Right? And then for NMS, obviously discontinue the offending agent. However, it could be difficult. Imagine if I gave a patient in the ER a dose of haloperidol and then they develop it. Like I can't really discontinue the drug because it was only a one-time dose anyway. But what you need to do is you got to cool the patient off. Either IV fluids are cooled or ice packs, or whatever the case may be. Hydrate them up, and then dantrolene is going to be our drug of choice here. Dantrolene is something else you'll also see for we call malignant hyperthermia. Yeah, we'll talk about that later. So yeah, so 2 places you'll always find dantrolene in the hospital. It's going to be in the OR because you can see it associated with like inhaled anesthetics, and then you also find it in the ER. The 2 places you always find dantrolene. But basically what it is, it's a peripheral muscle relaxant. So if you have someone with that lead pipe rigidity and they can't relax themselves, you can try giving things like benzodiazepines and things like that. They're still really contracted. This is where you're going to give them dantrolene, and that will help to relax that and help to decrease things like rhabdomyolysis and potential renal failure secondary to that, all that good stuff. And then the other thing we could do, if it's due to dopamine receptor blockade, well, why don't I just agonize those dopamine receptors? That's where something like bromocriptine, the dopamine agonist, can come into play. Okay. So here's a table that goes over the side effects and how to actually treat those. So kind of keep that in the back of your mind. So if I said, you had a patient came in, little Johnny got into grandma's haloperidol, and they're all of a sudden, having severe contractions, what would be the treatment of choice? You'd say Benadryl would be a good option there, right? Cogent and Artane, any of those would be fine agents for that. So just be aware and kind of use this table to review that stuff. Okay. Anyway, so any questions so far? All right, I'm going to stop there.